And yeah, so low-dose naltrexone was brand new to me. When I first heard about it, I was pretty skeptical as well. Usually when you're using drugs that are at such low doses, you're not going to get much of an effect. And I figured, like most people do, that, this could very well just be a placebo type effect. And there might be some of it. That's what's tricky about having studies about low-dose naltrexone. I'm really happy that Linda and Dr. Zielsdorf mentioned that it's not a very expensive drug. It's one that, Mark Drugs isn't making a ton of money on it. It's not terribly expensive. It can cost, $30 per month. And it's not really going to be something that will break the bank as far as, an expense or for something to try once you get down to a dose that you're actually going to be tolerating very well. And hopefully it's appropriate for your particular condition. Now, when we talk about these studies that this low-dose naltrexone research trust.org is doing here, the studies that they're trying to get, especially for a big MS study, the one thing that they got going for them is the cost of the medication. Usually when you're doing a placebo-controlled study, you're involving drugs that are brand new, that can be patented. I can't patent low-dose naltrexone. No matter how good of a formula I come up with, the low-dose naltrexone that I make, any other pharmacist can come by and take the exact same formula and make it, and hopefully they have a benefit with their patients. So there's no way for anybody to patent this. The one thing that low-dose naltrexone has going for it is its cost. Since it's been around for such a long time, it's relatively inexpensive. So just getting a big enough group of patients and a specific condition to treat, and hopefully we can start to get some of these studies done, which is the ultimate goal of the LDN Research Trust. So hopefully that is something that can get doctors more motivated to get on board and start some of these studies. Now, I'm going to be talking about low-dose naltrexone from my perspective. This was based on interviews that a student of mine had through her course at she was on rotation here, which is the last thing you do before you become a registered pharmacist. But apparently all of these presentations have to start out with something like this. So a famous quote by Abraham Lincoln, everything I'm saying here is not FDA approved. Now, low-dose naltrexone, the drug itself, naltrexone is certainly FDA approved. The low doses are not meant to diagnose, not meant to treat any specific disease. But based on my experience and what I've seen, doctors, patients, I even have some veterinary instances where they do have an effect in certain dogs and cats who have usually cancer, but sometimes used in IBS. Anyway, here's a little picture of naltrexone. What you might know it as, or what you might see more commonly, is this 50 milligram naltrexone tablet. It just comes off the shelf. It does require a prescription, but it does come off the shelf. It does not need to be compounded when we're dealing with these 50 milligram doses, generally 10 times higher the dose that we use in the low-dose naltrexone patients. It was FDA approved a while back, only for opioid dependence at first. So when it was first discovered, Vivitrol was used just for opioid dependence because it actually blocks the strongest of the opiate receptors. It takes the place of any sort of opiate, whether it's endogenous, your own endorphins, or exogenous, like hydrocodone or something like that, that comes from the outside to actually promote pain relief. What it does is it actually gets in place of the receptor to make sure that those medications are, whether they're from an outside source or whether your body's making the endorphins, make it so that it doesn't work as well. Later on, it got some FDA approval for alcohol dependence as well. It does not make it so that you do not get drunk if you have alcohol. And it can be used in something called the Sinclair method for alcoholism, where what it does is it doesn't block alcohol from working, but when you have an alcoholic drink, instead of your body still does actually release endorphins, but it blocks those endorphins, so you get less of a negative feedback loop. And that's why it was actually approved for alcohol dependence later on, after its known mechanism, where it actually just blocks the opioid receptors in your body. So you're going to see this as a common theme, this lack of sufficient clinical studies. That's the whole point of what we're doing here. That's the whole point of the LDN Research Trust Fund, because we need to start getting some clinically significant studies that actually show what this can do, what we know already, and how people can actually get a benefit from using this medication that has very, very few side effects.
Sorry, Craig. That's exactly what I just want to say, is that the number one roadblock of preventing a doctor from basically getting that prescription to you, Craig, is the patient saying, hey, can I try this? And they give the nice handy dandy guidelines that we wrote with all of these good evidence and all of this stuff. And the doctor goes, and then goes to PubMed and says, no randomized controlled studies. No.
Exactly.
Lack of sufficient clinical studies is the number one deal breaker for this being mainstream.
And that's why it's great to work with open-minded physicians who look at the side effect profile of something like this and say, well, at the very least, it's not going to do any harm to my patient. And when I go through the side effects, you're going to see there's not much to report here. But for the most part, since it's not FDA approved at these low doses, a lot of conventionally minded physicians will automatically push you off and say that it's not something that they're willing to try. And I even get some strange questions from physicians. They've been doing this for years. Say, isn't that a controlled substance? No, it's almost the opposite of a controlled substance. It's something that people use to stop using controlled substances, it's usually at the higher dose, but there are times where low dose naltrexone can be useful in a psychiatrist's office to reduce the temptation and the compulsion to reach for controlled substances. Either way, when we were talking about the regular naltrexone, this was the regular dose, look, starting at half a tablet, 25 milligrams up to 200 milligrams per day versus 0.5 milligrams to 10 milligrams per day. I've seen it a little higher and I've seen it a little lower, but that is kind of what we're going for. This low dose naltrexone, roughly 1/10 the amount that it was available in the commercial tablet. But the most of the indications are for some sort of autoimmune condition. I see it used for psychiatric conditions, but for the most part, I see something about your body is attacking itself. For some reason, your body is inappropriately targeting your thyroid or perhaps your own joints and rheumatoid arthritis as a foreign invader, when that's not the case. So this naltrexone, this low dose naltrexone, is often used in autoimmune conditions. Now, what I like about the new edition of this book, we talked about the first book that came out, I believe, in 2016, the low dose naltrexone book was great. And it actually opened my mind. I had been I'd been dispensing the low dose naltrexone for quite some time at that point. I don't get a diagnosis every single time a prescription comes my way. So I didn't necessarily know what it was for. At that point, I was thinking it was just Hashimoto's and rheumatoid arthritis. And boy, was I wrong, especially when I learned about what it can do in psychiatry. But the new book touches on the very low dose naltrexone. And actually, Dr. Zielsdorf's chapter in the second volume of low dose naltrexone book, it actually mentions this drug, oxytrol, that is actually right now in the process of getting FDA approved. Oxytrol is a drug that contains oxymorphone or oxycodone and very, very small doses of naltrexone. Still, right now, it's not FDA approved, but at least we're starting to, get our foot in the door. And there are actually people using low doses of naltrexone, lower than the ones that we're even usually talking about, in the micrograms. Going back to the low dose naltrexone, we're talking about 0.5 to 10 milligrams. Very low dose naltrexone has a lot of promise, and we're starting at 1 to 5 micrograms. There's 1,000 micrograms in 1 milligram. So this is as close to a homeopathic dose as you can get, but you actually have measurable amounts of naltrexone in a drug that's being studied right now called oxytrol. And it's kind of counterintuitive. Why would you put an opiate blocker along with an opiate? Well, the idea here is these are for the folks who actually need opiates. They need opiates to actually function in life. And there's plenty of legitimate reasons for that. If you have serious injuries, something that is chronic pain issues where when you've tried everything, they simply don't work. Or if you've been in a car accident and you've had structural damage that's just not going to be repaired through surgery, there's a legitimate place in medicine for opiates. it has been overprescribed, and using something like the very low dose naltrexone can make it so that your body stays sensitive to lower doses of opiates. Instead of having to go from hydrocodone to oxycodone, perhaps using very low dose naltrexone in the microgram range can keep it so that that Vicodin that took the pain away continues to do that without having to depend on higher doses or going up to the next level of a stronger medication. So in this instance, you actually are using naltrexone at the same time as you're using opiates, and you're doing it deliberately. But to move along, we are going to be talking about just some of the indications. Now, these are some of the ones that were talked about in the first book. The volume 1 discussed each of these, and actually volume 2 gets a little deeper into Crohn's disease and the thyroid disorders. What I really like about volume 2, and I wish I put this slide on there, is it actually gets into Lyme disease. Lyme disease is something that's, well, especially in this region, it's underdiagnosed. It's often lumped in with fibromyalgia. People misdiagnose Lyme disease and they consider it fibromyalgia because they can't really explain where these symptoms are coming from. But at the end of volume 2 of the low-dose naltrexone book, they actually dig deep into how it can be used for Lyme disease, which, you know, is an infectious disease, or at least it starts that way. But people who have had it for a long time, it ends up having a lot of neurological manifestations. But we do talk about Crohn's disease. What's nice about when they use naltrexone in something like Crohn's disease, not only do the patients start feeling better, that's all fine and good. You could put a camera down there to actually see what's going on. Crohn's disease is inflammation of, well, it can be anywhere in the entire GI tract, but a lot of it is actually in the small and big intestines. And they actually can scope you to actually make sure that when there was a lot of inflammation before, after low-dose naltrexone was introduced, not only does the patient feel good, which is subjective, but they actually see healing of the gastrointestinal mucosa, which is objective. You can see a before and after and get some ideas of how well the low-dose naltrexone worked for that specific patient. There's a couple of different theories behind how this works, and actually they're not competing. They're basically, they can actually work together quite as well. Now, when I first started learning about this, the endorphin surge theory, I mean, that hit me right away. I could picture that in my mind. The glial cell theory gets a little deep, and it's something involving certain cells in your brain that until not too long ago, they thought they were just structural cells, but no, glial cells that are just in your brain. They do more than just hold up your brain. They're not just the structure of the brain. They actually have their own activity, and that's where it gets a little bit deeper. But they actually, the theories are separate, but they complement one another. When we're talking about the surge theory, what happens with these low doses of naltrexone? Once again, not 50 milligrams where you get like a complete blockade. What you're getting is just a little bit of a blockade. Just, it's only there for a couple hours, and it's not completely blocking every single endorphin receptor. What it's doing is just blocking a number of them and not too hard. And what happens is your body thinks, well, I'm not making enough endorphins. And there's a lot of different mechanisms like this in the human body where when it senses it's low on one thing, then it senses that and it increases, as a reaction to that, it'll increase another hormone. That's what's happening here. Low-dose naltrexone moves in and blocks the opioid receptor, but just a little bit. Your body responds by producing more natural endorphins. And what those natural endorphins do is go into the body, go throughout the body and do what they're supposed to do, which is usually reduce inflammation and lessen pain. So you're kind of tricking your body to think it's endorphin deficient. And as a response, your body goes and produces more endorphins. One of the things that happens when you produce these endorphins is you reduce these inflammatory cytokines. Now, cytokines has been getting in the news a little bit lately. If anybody's heard of the cytokine storm, that's something that is described in the end stages of COVID. This is not a COVID medication. This is definitely not FDA approved for COVID. But what happens usually when patients are diagnosed with COVID and towards the end of their disease state, all these cytokines flood the lungs all at once, basically, a hyper reactive autoimmune state where just too much is going on in the lungs all at once. It's a defense mechanism, but it's disproportionate. And by reducing these cytokines being made and reducing the amounts that actually end up in the lungs, there's implications that there might be some sort of usefulness of this in those types of patients. So the bottom line is the cytokines themselves, just reducing your body's predisposition to making those cytokines, which actually cause inflammation, or it's a signal for your body that something is injured. We need to actually address this, and it just creates the inflammation. It's the on signal for inflammation. Another thing that it can do is hopefully activate these natural killer cells. Now that sounds bad. You don't want natural killer cells in your body, but you do. These are the things that are the first line of defense when it comes to anything, any sort of pathogen that's coming into your body. So these things being active and alert, low-dose naltrexone can help with that, making sure, especially now that your vitamin D levels are accurate, these are things that activate your natural killer cells. Your natural killer cells are the things that first recognize invaders and try to get rid of them before they become a serious problem. And another thing that it can do is it can reduce the killing of the myelin producing cells that actually are what is the cause of MS, or what people get when they have MS is these myelin producing cells, they die off. What myelin does is it kind of coats your nerves. So when your nerve signals, they send one from one end to your nerve to the other and kind of pass a signal along. What expedites that process and makes it a little more efficient is this myelin that actually wraps around the one end of the nerve. When the cells that make that myelin sheath start dying, that's when people get diagnosed with MS. That's just what's going on when people are actually having problems with the MS type symptoms, weakness in the legs, overall weakness and pain throughout. And then another thing it can do is stimulate the mucosal healing, like I discussed before with Crohn's or inflammatory bowel disease. It can actually help where there's a lot of inflammation in the guts, in the lumen, usually in the large intestines, and they can actually show that by increasing your body's natural production of endorphins, you start to reduce the inflammation and start to promote the healing inside the gut. And you can document that with the camera. Now, the glial theories, like I said, was a little tougher for me to wrap my brain around. Glial cells, I think even in pharmacy school, they were teaching me that they got function, but it's minor, and most of it is to be the I-beams and the structure of the brain to hold all the nerves that are doing the important work. Well, these glial cells are there just to kind of hold them in place, make sure that the brain has substance and that the neurons are protected. And this is not true. When they're activated, unfortunately, it can actually cause a sensation of pain. So by the neurons or the glial cells being activated, it actually activates the nearby neurons as well. And what the low-dose naltrexone does is it acts on the toll-like receptor that is inside the nucleus of these glial cells that can actually reduce the amount of the cytokines that are being produced. So naltrexone, not only does it block the opioid receptor, but it also blocks this toll-like receptor that exists inside the nucleus of the glial cells, which exist in your brain, kind of starting off the cascade that you're going to be experiencing pain and signaling to other places in your body that there should be inflammation. So just to recap the toll-like receptors' role in this whole thing, well, once they start producing this protein, that's when they start, the cytokines will actually result in increasing pain and inflammation in other parts of your body. And so sometimes this can explain how people with fibromyalgia, which is usually something that when doctors have, they can't pin an injury, they can't really explain why you're in the type of pain that you are and why the pain is so diffuse, or why when a very simple little gust of wind can cause so much pain throughout your body. They like to throw a lot of antidepressants and gabapentin and all sorts of other medications at them because they're just not quite sure how to treat this type of pain. Well, by using these low doses of naltrexone, you're blocking that toll-like receptor in the glial cells to hopefully reduce those types of symptoms. And I found this little chart that actually sums it all up. And we're even talking about, this is the endorphin theory, where it increases the endogenous endorphins. And then this one would be more of the glial theory. But then they have more that are in response to the exact area of the body to hopefully promote healing, especially this one down here with the Crohn's disease and how it can actually help stimulate your body to repair damaged tissue that was not damaged by something that you ate, although that does play a role. It was damaged because your body is already tuned in to attacking itself. Now, this is really where the rubber hits the road. This is where me as a pharmacist first got introduced to low-dose naltrexone. I need a prescription for 1.5 milligrams of naltrexone. What are you talking about? That dose is so low. How can you do anything? Well, usually that's where we start. 1.5 milligrams is a typical starting dose. When I have patients start low-dose naltrexone, I love to start them out at 1.5 milligrams where they can actually have enough capsules to double up and triple up. Most of these conditions that we're treating, the target dose is about 3 to 4.5 milligrams, but we want to make sure that the patients tolerate the medication. If they don't tolerate the medication, well, then we're going to have some trouble where they're not going to take it in the first place. And there's things that we can do about the timing of when you take it. And actually, I have some patients who take smaller doses multiple times per day. In fact, I got one story that just came up today that I'll tell you in a little bit about a patient who is dealing with small nerve neuropathy. But you typically start with 1.5 milligrams. You tolerate that. And then after a couple of days, maybe a week, you go to 2 of those, equaling 3 milligrams. And then after that, if you tolerate it, you go to 4.5 milligrams. When you're getting it from my store, I usually break it up into 3 capsules. This gives them the opportunity to try the 4.5 milligrams. If they don't tolerate it for whatever reason, then they go back down to the 3. The trick is to stay at the highest dose that you tolerate for a little while. And then depending on what condition you're treating, you get either some blood tests to see if it's working. If we're talking about Hashimoto's, and maybe we just have to rely on subjective things like your pain level and see if you tolerate it at certain different doses. But the idea is titration and giving the patient the power to titrate themselves. That's key. That makes them buy in a little bit more, and they have control over how this drug is going to affect them and if they're going to have side effects. There are some folks who are just too sensitive for this, though. Even the 1.5 just, knocks them on their rear because it's just too much, and some people are more sensitive to medications than others. I see it all the time. I can start them at 0.5 milligram in a capsule. I could start them at 0.1 milligram if they really want to. It would probably make some more sense to throw that into a liquid as opposed to have that as a capsule where if you're meant to adjust the dose, you can do it a lot easier with a liquid. But the maintenance dose, where our goal is typically 4.5, but if they don't tolerate it, the highest dose that they tolerate. Also, when we first started doing this, I was taught that you're only supposed to give it at night. This endorphin surge that naturally occurs in humans typically happens upon, once you wake up. In fact, it's pretty common in most mammals. Upon arousal, that's when you usually have a spike of endorphins. So by taking this low dose at night, hopefully it wears off in 6 to 8 hours so that your body responds by producing more endorphins in the morning than you would without the low dose naltrexone. But what people do if they just don't tolerate it at night. And one of the side effects that I'll get into, can be vivid dreams. Well, someone with certain conditions, that might not be a good idea. So taking it during the day is better for those particular patients. And down the road, once they tolerate the medication, perhaps experimenting with a nighttime dose down the road, it could work. But I got people who take this just during the day. And I did speak with one of my patients today who's taking it a couple times per day. And it just seems to work out better for those specific patients. So it doesn't really matter when you take it, but I typically start patients at 1.5 milligrams, taken at bedtime, and try to titrate your dose upwards. Now, the side effects of the low-dose naltrexone are minimal. I mean, you could see this. Vivid dreams, that's number one. That gets reported quite a bit. And some people like them. You know, if it's a cartoon and you're just having a good time and you got, doesn't freak you out, absolutely, have at it. It's the PTSD patients. There is implications and usefulness for these PTSD patients, especially depending on what has caused the PTSD. If it is an injury, then you don't want them to relive that in a vivid way. So vivid dreams, cartoonish dreams, are what people report. Insomnia is described more as a result of those vivid dreams. It's not that they can't get to sleep. It just sometimes they wake up in the middle of the night with a strange dream that they can't shake out of their head. And so I would call that secondary insomnia. It doesn't really keep you up. It's not an upper by any means. Nausea doesn't happen too often, but anytime you throw a capsule down your esophagus, there's always a chance for that. So it's reported, and I would say diarrhea should probably be reported a little bit more often. The mechanism of action of this low-dose naltrexone is to block the opiate receptor. When you're talking about opiates, what opiates do is they activate the opiate receptor, and when you do that in the bowel, that causes that constipation. So by using an anti-opiate, naturally, sometimes patients do experience transient diarrhea that usually goes away within a couple days. Going back to the vivid dreams, that usually goes away after a dose change. If they come back again, like if you go from the 1.5 to 3 milligrams, that's usually when you get the vivid dreams, when you change doses or initiate it. But those also tend to go away within a week. When you're talking about the regular doses of naltrexone, this is just a couple of the side effects. So we're talking about potential side effects of a drug at 50 milligrams. You got to extrapolate downwards and see the side effects that are possible with low-dose naltrexone at 1/10 the dose are minimal. And one of the things that people can't experience, especially if they are dependent on opioids, is some withdrawals, because that's just how the drug works. Now let's just take a look at some of the side effects that you can expect when you're using very common medications for rheumatoid arthritis. This is just a very small amount of the possible side effects. I'm not even going to bother reading them to you because, well, the idea is that there's a lot more side effects to conventional treatments for something like rheumatoid arthritis. People use, and that doesn't mean you can't use naltrexone with patients who are already using these medications. Just the laundry list of possible side effects is significantly smaller in standard dose naltrexone and even lower in the low-dose naltrexone. So something like methotrexate, which is a staple, which is something that actually a lot of conventional rheumatologists really encourage you to start using earlier rather than later than rheumatoid arthritis. I got nothing against that. It is a very effective drug. It's been around for a very long time. But if you can use something that is significantly less toxic, interacts with a lot less drugs, and has no, withdrawal effects, well, I would say if and when I possibly get diagnosed with rheumatoid arthritis, I'm going to try something like low-dose naltrexone first and see where that gets me versus diving right into the methotrexate, or down the road having to use the biologicals that are kind of the newer class of medications, which once again are effective. They have their place. Naltrexone's not going to replace them by any means, but it might be something to use along with these medications, or might be something that you can use before you have to use these medications. Because once you go down this route, it gets tough to come back. But we often have patients use them together and have no problems whatsoever, hopefully just an improvement in their overall condition, especially with rheumatoid arthritis. Talking about drug interactions, well, the high dose naltrexone has some potential drug interactions. There are some rare drugs that very few people use. I'm not worried about direct drug interactions. What there is the opioid interaction. What it does is it actually blocks the opioid receptor. So if you need opioids to actually control your pain, low-dose naltrexone might not be for you. So by using low-dose naltrexone inappropriately, if someone who's dependent on morphine just to get through the day because of a pre-existing condition, it might not be helpful for that patient to try low-dose naltrexone. This might be an ideal patient to use the very low-dose naltrexone that I touched on earlier, where they're actually just using micrograms of doses to make sure you don't need to go to the higher dose of morphine, or you don't need a stronger, longer acting opioid to control your pain. And what's nice about it too is that when you're using the low dose naltrexone, if you're going in for a procedure that might possibly require you to use an opioid temporarily to control that pain, all you got to do is discontinue it for a couple days and you'll be fine. Now, when it comes to tramadol, tramadol is one of the weakest of the opioids, very popular drug, and it affects people differently. Some people take a tramadol and they're just out like a light. Some people take a tramadol and it doesn't do anything to them. And tramadol itself just reacts differently in people, where it can actually cause, some people to get jumpy and get, seizure-like side effects of it. But it's just one of those drugs that's considered one of the weakest of the opioids overall. I do have a number of patients, including the patient I spoke with who has small nerve neuropathy today, who can use tramadol as an as-needed basis, ideally separated as far away from the naltrexone as possible. So using opioids doesn't mean you cannot use low-dose naltrexone. It just depends on which opioid, how often you need it, and how strong that opioid is. Because I do have a number of patients who use tramadol as needed, infrequently, and have to use it less frequently now that they're using low-dose naltrexone. And when it comes to what I do here, as I put this drug and I make it into a way, a capsule and a tablet and a liquid, make it into a way that you can actually use it. We even have a couple of human patients and a couple of feline patients who have used the transdermal version of naltrexone as well. So it can go through the skin if for some reason taking it by mouth is just not an option. This is the tablets. Once again, this is nothing. I mean, I got this stuff. I can dispense it, but I often don't. And when I do, it's just few and far between. But this is what's in the naltrexone tablet. A number of ingredients, most of which I can pronounce, but I've never heard of this one. Anyway, there's 12 ingredients here that go into the final formulation of the off-the-shelf naltrexone tablets, which is why if you are going to go to a compounder, you're going to want to ask where they're getting the naltrexone, because if they're using these tablets, most people aren't super sensitive. They could probably tolerate all these ingredients. I mean, there's a reason why all these ingredients are in the commercially available tablet that's on the shelf at your local pharmacy. But it doesn't have to be that complicated. We don't have to use all these ingredients when we make our capsules. They got their place, and when they're making thousands, hundreds of thousands of doses at once, perhaps you need all these fillers just to make sure that the batches turn out right. Well, when we're talking about what we make at Mark Drugs, I make the naltrexone capsule. Ingredient 1, naltrexone. Ingredient 2, sodium bicarbonate, which is something that I use because it's synthetically derived. It's just it's baking soda. And so I'm not worried about people having allergic reactions to it. And what the heck is riboflavin in there? It's just riboflavin is B2. It really has no function in here. It just happens to be yellow. I'm mixing one white powder with another white powder and putting it into a clear capsule. I want to make sure that these are actually uniform and that the naltrexone that's in one capsule is the same amount of naltrexone in the next and the next. So riboflavin's role in my capsules is as a coloring agent, so I don't have to use yellow number 17. And then I use a vegetable capsule because people are kind of prone to going towards using something that's as clean as possible. 4 ingredients are in my capsules that I make at Mark Drugs in the North Shore. Now, my mentor, Dr. Mark Mandel, they got a tablet machine over at Roselle, and he brilliantly put together this formula for the tablets that they make over there. Naltrexone, 5 ingredients: naltrexone, inositol, silica gel, and Avicel, and magnesium stearate. All these things are put together in a press, and what they do is they have a couple of different type of tablets over there. They got mini tablets that are just, microscopic. They're tiny. And they're ones that are available in 1.5, 3, and 4.5 milligram. But Mark was smart. He figured that people are going to be doing these titrations. It might be more convenient for them to have a nice 3 milligram tablet that's slightly larger with a nice little score down the middle. What this does is that you can cut it. And when you cut it in half, you're doing 1.5 milligrams. When you take the full tablet, you're taking 3. And when you take 1.5, you're taking 4.5. Depending on which one you tolerate the most, I can make a capsule with that number of milligrams. They can make a tablet with that number of milligrams. So you end up just taking one tablet or capsule every evening or daytime, should you be one of those patients. And the transdermal one is 2 ingredients, but that lipoderm is a specific base. What's important about that particular base is that it actually pushes drugs through the skin much better than if it were on its own. So it enhances the absorption of drugs and gets naltrexone into the bloodstream, even though it's not a very lipid-soluble medication. It doesn't really go through the skin very easily. So by using lipoderm, you can actually speed that up. And one of the ones that we use, especially for my really sensitive patients, the ones who just can't tolerate any sort of different types of fillers, and maybe you need a much lower dose. Remember, I did mention earlier that we sometimes start patients at 0.5 milligram. I've had a couple patients where we start at 0.1 milligram. If you do that in a liquid, it's a lot easier to titrate the dose because you can make it 1 milligram per ml and have them just start out at a half ml and then go to 0.6 mLs and increase very, very slowly and deliberately. And that's just 3 ingredients: naltrexone, vitamin C, and a secret proprietary blend that actually contains 2 parts hydrogen and 1 part oxygen. So it's something that's about as simple as possible, something as clean as possible. So if you have allergies to any types of different, fillers or whatever, this might be the way to go. And if you're also one of those people who are super sensitive to dosage and dosage adjustments, this is a very good way to do it, where I've actually had it tested at room temperature for a couple months. And if you keep it cold, it's good for even a little bit longer than that. The vitamin C, all it's doing in here is actually keeping the naltrexone and the secret sauce at the right pH to make sure that it stays stable for the amount of time that you're going to be using it. And I just had this slide in here as an example of what I just got lying around my office right now. 0.5 all the way up to 6. And we did mention earlier, and Linda, I'm very happy that she mentioned that the folks who are at first trying to do slow release, there are actually reasons to do slow release in certain specific patients of naltrexone at lower doses. Most of the autoimmune conditions are not them. They have more to do with behavioral issues and weight loss. So not all naltrexone is the same. My sodium bicarbonate is not going to slow down the release of this naltrexone. It's going to get into your system pretty quickly. But there are times where using a slow release mechanism, because they're using it for weight loss or they're using it for behavioral modification, is appropriate. Here's how you get it. You set up an appointment with Dr. Z. And if that Dr. Z is too far away from you, I got another Dr. Z up here who can help you. Bottom line is you do have to find a prescriber who will and is willing to write this prescription. It's not going to be as hard as it was when Linda had to go searching for somebody to actually write this medication, because it is, while it's off-label, once you actually demonstrate those or can show the side effect profile, what can possibly happen if I start using this for whatever condition I might have? What's going to happen? What's the worst that I'm going to lose a night's sleep? And guess what happens? You stop taking it, you get that night's sleep, you can sleep again. Or you just move it to during the day and you don't have to worry about it either. You don't need any specific credentials. There are people who, once again, practitioners, people who have been prescribing medication for 20 years are nervous because they think it's a controlled substance, and it's not. It's something that can actually help people who are having trouble with controlled substances. But it is only available by compound, meaning we have to make this from scratch. And I guess there are some pharmacies who might go out there and crunch up those 50 milligram tablets and add a filler in there and make it an appropriate dose. There's really nothing overtly wrong with that. But if you're looking to get a nice clean product, talk to a compounding pharmacy and ask them what the ingredients are, what inactive ingredients are in their naltrexone capsules or tablets, transdermals, or what have you. And you'll find that most of them are willing to actually pay the extra money to get the real naltrexone in its pure form and encapsulate it into the doses that are appropriate. Just a couple other things I wanted to mention. I mean, I know we're all humans here. At least I hope most of the people on this call are human. But those who have non-human companion pets, such as this pretty little cat and this adorable little dog, there are implications that low-dose naltrexone can be used for pets, especially when we're talking about behavioral issues. But when I've described it, when I've dispensed it here, I've often dispensed it kind of as a last-ditch effort when the animal was still comfortable but had tumors that just weren't going away. And the idea is to hopefully with this and another medication called piroxicam, we can hold off the tumor to slow down the spread of the tumor and hopefully give the animal a better quality of life while they're still around with their loved ones. Target doses are generally the same, but you might start lower with smaller animals, start at the 0.5 milligram dosing. And while dogs are typically dosed at night because they actually sleep at night, cats are pseudo-nocturnal. So dosing them in the morning is appropriate, and trying to give a cat a capsule is difficult. And that's one of the many things that we do here at Mark Drugs, is make sure that cats don't have to have capsules. So that's where the transdermal one can come in and be effective. But dosing in the morning is more appropriate if you're trying to stimulate that natural endorphin surge. And I also got to mention another thing that Dr. Zielsdorf touches on in her chapter on chronic pain in the book is the combination with cannabidiol and how it can actually be used where both of them together can really have a high impact on reducing inflammation. Other herbs like turmeric, when inflammation is what we're trying to treat, especially visual inflammation, when you see someone who's suffering from rheumatoid arthritis or who has been suffering from rheumatoid arthritis for years, you can see the deformity in their joints and the pain that they're experiencing. Using something like a topical CBD and an ingested LDN to hopefully get the anti-inflammatory effect directly and from within by the boosting of the natural endorphins, or taking CBD by mouth as well, taking both LDN and CBD orally to hopefully reduce pain and inflammation in certain areas of the body goes a long way. And when we're talking about those Hashimoto's patients that Dr. Zielsdorf has a lot of experience treating with LDN, CBD, and also her amazing medium release or modified release thyroid preparations that we make here to actually address people's Hashimoto's thyroiditis as a individual patient, getting specific doses for those individual patients using a couple of different things: low-dose naltrexone, CBD, as well as the as well as her modified thyroid preparations that we make here. So for the most part, I'm here to answer some more questions that you might have about the formulations of the different medications that we make here. I even have a couple of demonstrations to show you as far as like what you can expect if you're going to be getting low-dose naltrexone from us.